And I request all our experts and speakers to stay on for the next session. Also, let us debate. And after that, we'll definitely have this discussion continuing. And since we have a live case also after this debate, I think we'll just go ahead with the next session and then have a discussion. And with this, I welcome for Let Us Debate session, we have Dr. Madhu Sridharan from Trivandrum and Dr. Sanji Roy from Jaipur, Rajasthan to discuss. And I'm sure that our speakers shall ensure an exciting session and shall facilitate lots of learning and help us in enrich our knowledge. In the expert panel, we have Dr. Lakshman Das, a very senior intervention cardiologist and HOD of Madras Medical Mission Cath Lab. And we as our international guest speaker, Goran Stankovic is going to be with us. Dr. Roni Matthew is going to continue with us, and Dr. Sengu Tuvel. And of course, very senior and respected Dr. M.S. Hiramath is going to be here. To take us all through the session, I welcome Dr. P.K. Goyal, who will be moderating this session. Dr. P.K. Goyal is currently the professor and head of cardiology in STPGI, Lucknow. He has keen interest in coronary imaging and chronic total occlusions. P.K. Goyal is the main soul behind starting coronary angioplasty program at PDCA and PDCA at STPGI back in 1991. Dr. Goyal is active course director in IJCTO. I hereby request Dr. P.K. Goyal to take over the session and let us debate. And it's over to you, sir. You can just call the session, sir.
Okay. Thank you, Dr. Selvamani. And I think I was just attending the sessions earlier and it was very interesting. So we had two nice talks. And now, as you all know, the topic is whether provisional stent or two stents and what exactly is provisional stent. So, and we can debate on it. Well, I don't think truly this is a debate, but yes, to get systems right, let us see what the two speakers have to say. And so we are going to debate on provisional stenting versus two stents right from the beginning. So in favor of provisional stenting as the key strategy, we'll have first Dr. Madhu Sridharan, who's going to speak for 10 minutes. So Dr. Madhu Sridharan, please, on provisional stenting for bifurcations.
Hi, hi. Am I audible and can you see the screen?
Yeah.
Thanks, Silvamani, for this invitation. And this would be quite similar to what Dr. Stankovic just said. So there would be lots of overlap between the two. But yes, provisional would be the best, the key strategy for better clinical outcome. This is a graph which shows the death, MI, and stroke over 3 years in the Excel. And we see that the numbers, though statistically not significant, are lesser with a provisional approach than a planned two-stent strategy. Yes, we do agree that the kind of patients who had a provisional
Silva.
was less complex, majority of them at Medina 100 as compared to the ones which had a planned two-stent, which is more complex. But must remember that the patients with two-stent strategy had worse events as compared to a provisional strategy. Now, and this is seen in the ESC guidelines as well, which shows a provisional strategy being given a class 1 level A recommendation, while a true bifurcation may be given a 2B with a DK crush technique. Now, the question is, should we use one stent or two? We got 11 randomized studies with tests comparing 1 versus 2 stent and 8 meta-analysis, which show there's no advantage in using a systematic 2-stent approach. A stepwise provisional T is a gold standard for most bifurcation, but this does not mean there'll be occasion when you need a 2-stent strategy. This is a 1 versus 2 stent, the meta-analysis of RCT, and the primary outcome was all-cause mortality. And there was a 31% relative risk reduction with the provisional stenting. And this again was present even in long-term follow-up with a 37% relative risk reduction at 4.7 years. When you talk about ischemia at risk, revascularization is better than medical treatment when moderate to severe ischemia exists. Therefore, it's important to define the side branches that can cause more than 10% of ischemia. And this has been shown in the recent ischemia trial as well, that even patients with significant ischemia, they do quite well with medical therapy. Now, if you look at the frequency of side branches supplying more than 10% of functional myocardial mass, left main definitely, but in non-left main, only 20% or 1 in 5 of the non-left main side branches supply more than 10% of the functional myocardial mass. So a provisional strategy would be enough or would be good enough for majority of bifurcation. But we have to do a provisional strategy well. And these are the principles of bifurcation PCI. There should be protection only for non-clinically relevant side branches. Most important, you should limit the number of stents. A single stent layer, which is well opposed, would be great. And you should respect the original anatomy. And the basic strategy is to keep it simple and safe. The standard operating protocol for bifurcation would be the provisional should be the default in most bifurcation. Upfront two-stent strategy may be needed for a few which have a large side branch with a lesion more than 10 millimeter from the ostium. There's a long length of the side branch with calcium, and particularly when it's challenging to wire both branches. This is the diameters for the Murray's law and the Finet's law, that the D1 is 2/3 of D2 and D3. This was again shown by Dr. Stankovic. You had to wire both the vessels, predilate the main vessel, side branch dilatation as operator discretion, stent according to the distal reference diameter, proximal optimization as mandatory, optional case for a large side branch. It can be pot side branch pot or pot kiss pot, and an optional second stent. But if you have a second stent, kiss is mandatory, and you have to have a final report. Provisional is a strategy, and it does not mean one stent all the time. This is our most important thing that we have to keep in mind. You have to wire the side branch. It keeps the side branch open. It facilitates access to the side branch. It helps as an anchor, and it can be used to rescue jail side branch by passing a low profile balloon between the stent and the vessel if needed. Predilatation of the main vessel is absolutely important. It assesses the length of the stent proximal to the bifurcation for pot. For optimal stent expansion of the main branch, this is really important. And finally, it's a main branch status that determines the long-term outcome. Predilatation of the side branch is not recommended unless side branch access is difficult or you have severe disease or calcification of the side branch. Main vessel stenting, you have to have a drug-eluting stent. You should know your stent platform, as Ronnie Matthew has said before. Stent has to be sized according to the main vessel, and it should be according to the size of the vessel distal to the bifurcation, which avoids carinal shift and distal dissection, and a final pot is essential. Pot optimizes the stent and restores the fractal geometry, and has to be done before rewiring the side branch because it facilitates the side branch access, reduces the possibility of wire going behind the main vessel stent, as Dr. Stankovic has shown in the video. It helps wire crossing into the distal stent, and pot may be repeated if the wire cannot recross into the side branch. You must have at least 10 millimeter of the main vessel stent proximal to the bifurcation for a proper pot, because that's probably the shortest length of the balloon that's available. And it has to be non-compliant balloon. Short non-compliant balloon, the distal marker of the balloon should be just proximal to the carina. If it's too distal, it causes distortion. And if it's too proximal, it doesn't push the stent struts into the ostium. The proximal marker should be within the stent. If the entire stent is not covered with the balloon, it has to be pulled back and reinflated to fully open the proximal stent with the help of stent enhancing technology. This is from the EBC 15, which Dr. Stankovic has alluded to. This is the way ideal pot should be done. If it's too distal or too proximal, it does not serve the purpose. Side branch treatment, the fundamental advantage of a provisional approach is that side branch treatment can be done at any stage during the procedure. The distal strut has to be open, which leads on to scaffolding of the ostium, and the position of the wire cross can be seen with stent enhancing technology or with OCT, as has been said before. And use of non-compliant balloons are recommended to reduce side branch dissection. Side branch treatment in small side branch is just to keep it open. And if it's a large vessel, you have to wire both, stent the main vessel, pot, this can be followed by port side port, which has limitations because it can distort the main vessel, or port kiss port, which is the ideal one to do. And a report has to be done to reduce the eccentricity of the main vessel stent. A second stent would depend on the size of the side branch and result of treatment of the side branch. Two stent would be needed in 10%. It can be a T-tap or culotte and should be finished with a kissing balloon and a final report. So this is what we've been referring to. The main vessel, you cross across the main vessel, followed by port, side port, or port kiss port. And if you need a second stent, it has to be a T-tap or a culotte. And if the ostium is involved, then as Dr. Stankovic has said before, you can send it into the side branch followed by an inverted T, inverted tap, or an inverted culotte. So why are we talking about non-provisional strategy? Because all through we have been talking about how good the provisional is. Why should we talk about a non-provisional strategy? Because complex bifurcations behave differently. And we have the definition 2 criteria for complex bifurcation, which is the major criteria is a side branch lesion more than 10 millimeter, more than 70% distal left main, more than 10 millimeter, and more than 90% for non-left main. And the minor criteria would be moderate severe calcification, if you have multiple lesion, ankle less than 45 or more than 70, thrombus containing, main vessel RBD less than 2.5 millimeter, or a main vessel lesion length more than 25. If you got one major or two minor criteria, you have a complex bifurcation. So how do we treat a complex bifurcation? This is the definition trial, which is presented by Dr. Chen in PCR. And this shows that the 2 stent was significantly better than the provisional for a complex bifurcation. And this is a network meta-analysis of 5,700 patients with a coronary bifurcation, which showed again that the DK crush was better than most of the other 2 stent strategies. But the key issue here is the lesion length. If the lesion length in the side branch is more than 10 millimeter, you probably would need a 2 stent, which can be equally well done in a provisional, but probably a DK crush would be better, though it's more complicated. But you must understand that there's a thing called stent failure, and stent failure 1 to 5 years post PCI is 2% per year per stent with no plateau, which means it keeps expanding. So you have stent failure, and the more number of stents that you put in, the more number would be your complications as years go by. So this is a case which has got a bifurcation, true bifurcation. You got a pinching on the side branch following a stent, proximal optimization. There's a pinching of the side branch, which is dilated with a balloon, followed by final kissing balloon and a final report with a good result. But all provisional stent, you may not have a good result. As in this one, you had a stent from left main to LAD, but after dilating the side branch, resulted in an ostial dissection. So then you have a T-tap or culotte. Here we did a tap to the circumflex with a final kissing balloon and a good result. So if dissection happens, as Dr. Stankovic said, is not a complication, it is a part and parcel of the provisional strategy. So provisional strategy would be stepwise, logical, straightforward. It's reproducible, versatile. You can always stop when you have a good result. There's no prejudgment, and you got excellent trial outcome from the European operators. And this from David Heldick-Smith. So in conclusion, bifurcation PCI is a complex procedure. Majority can be treated with a provisional approach. Complex bifurcation may need a 2-stent strategy, but that would be a minority. DK crush has the most evidence amongst those 2 techniques, but the EBC main and BBK3 would refine the optimal technique. Stent failure occurs with time. It's 2% per year per stent. And the aim should be to limit the number of stents and to deploy it well, preferably with imaging. And individualized care should be the way forward. Thank you.
Thank you, Dr. Sridharan, for that nice presentation. And now I will invite immediately Dr. Sanji Roy to speak against the motion, in the sense he's going to speak on 2-stent plan strategy right from the beginning. So Sanjeev. Sanjeev, are you there? Can you hear? Is Dr. Sanji Roy is not audible? You will need to share your slides. Is there some technical help around? Yeah, I can see he's connected.
Can you hear me, sir?
Yeah, that's right.
Yeah.
Okay.
Yeah. Can you hear me?
Yes, you are audible. You can share your slides now.
Is my slides visible?
Yes, there is a, yeah, that's right. You get on to slideshow. Yes. Is there some technical help around?
Are my slides visible?
Yes. Your slide is visible. You are also visible and audible. You can go ahead.
Thank you, Dr. Silvamani, and thank you. Thank you, Dr. Silvamani, and thank you, Dr. Goyal, sir. It's been a real pleasure to have this debate. And I have to swim against the tide as Dr. Goran, who represents the EBC club, is a very proponent of the provisional strategy. And I'm going to discuss about two-stent strategy, where I would emphasize is just check the anatomy and straight away go to a two-stent strategy to avoid a complex bailout procedure. So as has been already highlighted, the challenge for the coronary bifurcation lesion is the suboptimal result with increased stent thrombosis, unplanned TLR and TVR. So obviously we have the provisional side branch strategy and two-stent strategy, where two-stent strategy, I mean the intentional two-stent strategy, not a bailout strategy. So the four important determinants of the outcome are the lesion complexity, the balloon technique. Balloon technique, I mean the PSK, that is pod, site, and case, the stent technique and the choice of stents, and optimization of the result if need be by using an imaging technique. So the bifurcation anatomy, as my friend Dr. Madhu was highlighting, is very highly variable and interacts with the clinical outcome. The most important things are the angle of the bifurcation, the side branch relevance, the extent of disease of the side branch, and the size of the main branch. So if you look at here, the lesion complexity, obviously in such cases, you try to opt for a two-stent strategy rather than a single stent. The most important is we need to know the predictors of the side branch occlusion, which is more dependent on the degree of stenosis, the plaque burden, the diffuse disease extending into the side branch, calcification and tortuosity, or if it is a thrombotic lesion, the angle of bifurcation, and if there is an impaired flow at the baseline and the vessel size. So we have various scores where we can look at the probability of the risk of occlusion. And the most important, as Dr. Madhu was also emphasizing, is to identify and protect the clinically important side branch. And clinically important means it should at least supply more than 10, it cause more than 10% of the ischemia. And more important situations like that can be when you have a very proximal disease, you have a pre-existing LV dysfunction and a viable myocardium, which is dependent on the side branch. And we should not react unnecessarily to an angiographic appearance of a carina shift and a plaque shift to decide for the two-stent strategy. The best practices have already been described by Dr. Goran and Dr. Madhu. And more importantly, if you look at here, if you have any risk of side branch compromise, a difficult side branch access, or a lesion length of more than 2 millimeter, I'll rather straight away switch over to the intentional two-stent strategy, more importantly, emphasizing on the balloon techniques and optimizing the result with image guidance. So let me show you a couple of examples. So this is again a 55-year-old gentleman with a prolonged chest pain. And if you look at here, we have a bifurcation, Medina 111, and a classical. And look at the diagonal. This diagonal territory, at least more than 10% of the myocardium. And if you look at it, goes as deep as the LAD territory, a significant branch, both artery diseased. So I think I would rather prefer for a two-stent strategy in such setup, because I won't want to end up in a situation where I have to bail out with a compromised flow. So with that intention, I go for wiring both branch, preparing them. And this is an OCT guided one where I can look at the length and the dimensions which we have to stent, and then look at the side branch. Yes, side branch was more diseased in the osteoproximal, and I could at least get an idea of the side branch stent, and then go for, this was a DK crush technique. If you look here, straight away use 18 millimeter 2.25 stent, crushed it, expanded the side branch stent to 2.5, and you can see here the wire cross through the middle of the struts. And this is what the wire cross looks here, right from the middle of the stent struts. And then recross, kissing, proximal main vessel stenting, and pot, again cross, do a second case, and then final pot, and that's the result. So this was again the result. There was some dissection flap quite remote from the stent edge, which was, I felt, non-significant because neither the angle or depth was significant. And this is what it looks like. A beautiful result with carina angle. If you can look at the carina, beautifully opened side branch and the main branch. And these are the final images. And this actually was a part of the a study of the bifurcation study which was going on. So there was an angiographic and OCT mandatory follow-up. So this is a 6 months follow-up of that. And if you look at, there was some disease in the ostial circ, which was little to me a puzzling. So I did again an FFR, which was RFR, and FFR was not significant here. And again, as the OCT follow-up, the stent dissection had healed. There's a beautifully patterned stent with nice, again, you can look at a pullback from the diagonal. And this is the carina, which looks like. So it was quite well. So this is the first case. The second case, again, this was a post-CABG patient. He had a graft to only lima to LAD. So we were wondering what was the reason for that. And you can look at here, there is a stump here of the LAD. So obviously LAD was grafted. There was a report written where the LCX had some 70-80% lesion, but we did not have any further clarification of that. So when we did an angio, we could find an anomalously arising LCX. And if you look at here, it's a bifurcation disease, very, very short stump, just proximally. So I don't think there was any other way of salvaging and rescuing the both branch. So wired both. The RCA lesion was tough, so I had to use an angiosculpt and cutting balloon. And then the best way to avoid multiple recrossing was, I think, the mini crush, which I used here. And after mini crush, optimize the main vessel, a pot, and again the wire crossing through the middle of the struts, a kissing balloon, a repot, and that's how the final picture looks like. And again, this was an OCT picture. There was another lesion in the distal LAD where there was a calcific nodule out there. But again, the FFR was not significant. So we left on medical management. So again, this patient has completed a follow-up 21 months, and his stress echo last year and this year has been normal. So he's on single antiplatelet therapy right now. And the last case, this is again another lady who had an angioplasty done some 6 months prior to this event. She had a chest jaw pain during her morning walk, and we did a check angio and we find a tight ostial circ lesion. This was just like it, and the FFR was very significant. And this was, we did an OCT, was like the case that Dr. Ronnie Matthew was explaining. We had a stent here, which was from the ostial LAD, but unfortunately, the stent had encroached the left main, and it was undersized and underexpanded for the left main, and that patient has some disease. So again, after the OCT, we actually found out that the significant lesion in the ostial circ. So we opted for again here, a DK crush technique. And after the DK crush technique, a pot, and final case, we did an OCT, which showed the very beautiful results. And that's how the final result looked like. This lady again has completed nearly a year of follow-up and stress echo is negative. So why upfront two-stent strategy rather than the provisional? So look at this, what Dr. Madhu was explaining. Upfront two-stent strategy, according to the last ESC guideline, was basically reserved for those with a side branch diameter more than 2.75, a longer lesion, or an anticipated difficulty in assessing the side branch or a true left main lesion. And the strategy described which are best for the non-left main. There was no compelling evidence of superiority of one technique over the other, but for the left main, it was DK crush. And the technical details is as per the EBC guideline. And this is one what he referred to. The provisional should be the class 1 and the DK crush should be the class 2B whenever preferred. But look at the references here. So this was based on a meta-analysis which was done in 2014. The second reference was published. This was based on the BBC and the Nordic trial. The third, the EBC2, again in 2016. And the final line in that is, look at the fine prints here, that shows that the DK crush had a superiority, and this was in 2017. But let's look at the contemporary approach to the BCI bifurcation. So we all know there has been a lot of refinement of the existing and new techniques have been described. All of this have been to improve the clinical results. Now, specific bifurcation technique should be selected, which is appropriate to the lesion complexity. So as Dr. Madhu was saying, the more complex lesion, yes, operate for a two-stent strategy. And this has been already proved by the DK Crush 5, which was used for the left main. And interpretation of the clinical trial should always account for the anatomic characteristics of the bifurcation lesion and appropriateness of the specific techniques, which often we find it missing. So definition trial, again, we are talking about hardcore complex bifurcation, not the run of the mill. And this definition trial, when complex bifurcation lesion was selected, this was prospectively tried in definition 2. And if you look at here, what difference it made the difference in the target vessel myocardial infarction and target lesion failure. So mind you, this is myocardial infarction, and which was again in provisional strategy is supposed to be less, but here it was quite significant difference. And if you again look at overall, there was some benefit in the two-stent strategy in complex lesions. And again, systematic two-stent strategy approaches was associated with significant reduction in one-year incidence of target lesion failure compared with provisional strategy. And this was driven by fewer target vessel MIs and clinically driven TLR. Again, this paper he already showed, that was the network meta-analysis comprising of nearly about 5,700 patients. And again, what you find is DK crush showed superiority over the other techniques, including provisional. And again, the target lesion revascularization was much less with the DK crush, as also the rank of probability analysis for all outcome interest. If you look at the green lines are DK crush, which showed its superiority. Yes, for simpler reason, a provisional strategy is okay. But if you talk about complex lesions, definitely DK crush outscores others. So this meta-analysis that showed that two-stent, there is no benefit of two-stent technique if the lesion length is less than 10 millimeter. But if it is more than that, yes, two-stent technique has a superiority. So to conclude, coronary lesions are of diverse with wide variation in the anatomy and the angles, the vessel diameter. The best technique is still a matter of debate. The philosophy of making complex matters simple has been supported by several clinical trials with improved outcomes in routine two-stent compared to the routine two-stent strategy. Most planned two-stent techniques were inferior to the provisional, but these findings are not applicable to all two-stent techniques, especially the treatment of truly complex bifurcation lesion, as was shown in DK crush and definition 2 trials. For the more simple true lesions, true bifurcations not meeting the definition criteria, yes, a provisional approach is okay. But for the side branch disease, if it is significant, definitely it is two crush. But most importantly, I mean, a provisional strategy can never end in a crush or DK crush for which decision for the side branch stenting must be made upfront. Because of all the techniques of the two stent, I think decay crush is superior. And at best, we can do inverse crush after the provisional, and inverse crush has not shown superiority in any of the trials. Thank you.
And yeah, yeah, it was excellent, sir. And since we are behind time,